Okay, we're live.
All right, looks like the stream is live. So, all right. Well, hi, everybody. Thanks for joining us today. And today we're going to be talking about evidence-based engagement. In other words, how do we leverage the principles of evidence-based medicine to transform the way we engage with HCPs? And in today's market, credibility really doesn't come from that loudest message or the highest number of messages. It really comes from precision. Those small shifts in language, just like small adjustments in a golf swing that can completely change where your message lands. I'm Brad Ansley. I'm with SilverEdge Performance Group, and I'm joined by Dario Priolo with JK Research. And we're going to start with a couple of quick introductions today, and then we're going to dive right into how your teams can apply the language and principles of evidence-based medicine to build trust, access, and influence. So Dario, if you want to kick us off with a little intro, why don't you go first?
Sure thing, Brad. Hi, everyone. My name is Dario Priolo, and my firm is JK Research. Brad and I have worked together in the sales training industry for a long time, worked together, and he's just been a wonderful colleague. And now we're both on our own and doing some really cool things. And I'm really pleased that I can accompany Brad today for this talk. Just one little housekeeping item. We are streaming this webinar on LinkedIn, so using LinkedIn Live. And what you can do is you can just use the comment box on LinkedIn if you have any questions. We'll try to answer your questions in real time, but if not, we have a little bit of time at the end where we can take them.
Yeah, good enough. Thanks, Dario. So a little quick intro for me. My background actually spans science, pharma, and sales leadership. I started as a bench microbiologist with a Becton Dickinson subsidiary, and then spent the next 22 years at Merck in sales, marketing, and market access. And then I created and led the global healthcare sales consulting practice at Sales Performance International and Richardson for about 17 years. So it's that mix of science, commercial experience. Those are the things that really drive my passion for evidence-based engagement. And that's the reason for and the rationale for the conversation we're having today. So with that, I'm going to pass it back over to Dario, who's really going to guide our discussion today and throw out some questions that get right to the heart of evidence-based engagement. So over to you, Dario.
Sure thing, Brad. So Brad, I know that you've said that the days of feature and benefit selling are over in pharma. What changed in the healthcare landscape to make that true?
Yeah, that's a good question. A lot of people, are looking for specific recent changes, but really to get the context of this, you have to look back over 15 to 17 years ago. And you'll see some of this on the slide here, but there were some macro drivers of change that were having an impact on healthcare. And that's the increase in population growth. People were living longer. You had the rise of the middle class. You had an increased disease burden, diabetes, heart disease, chronic kidney disease. And these are things that I know folks on this call they know a lot of this, but all these things drove the unsustainable cost of care. In fact, at the time, healthcare spending was outpacing GDP growth, and we're talking specifically in the US here. And that the impact of all that mandated some regulatory changes across the globe. And I want to hit on those just to solidify how they impacted the need for evidence-based engagement. So in 2009, you had the American Reinvestment Recovery Act, which was really on the heels of the Great Recession. So it was a stimulus package, but also laid the groundwork for in healthcare investments for organizations like the Patient-Centered Outcomes Research Institute, which is responsible for comparative effectiveness research and driving a lot of the guidelines that are out there today. It's also responsible for the High-Tech Act and IT adoption for Medicare and Medicaid so that you can get all that data into real-world evidence. And then in 2010, you had the Affordable Care Act, of course, which was all about coverage expansion for those folks that had lost their jobs during the recession. And it really began the payment and delivery reform in healthcare. It was all about cost containment. And this was they shifted here and forced the shift from fee for service for physicians to pay for performance, or what we've heard of the last few years as value-based healthcare. Now, what's interesting is it took all the way till 2015 for MACRA to come into play, which really put the nail in the coffin for fee for service and drove the value-based healthcare drove it home. So and what's interesting is that was passed in 2015, but the payment adjustments weren't realized until 2019 with high, and then there are more adjustments being solidified in 2022, and then it'll be reevaluated again in 2026. So the reason I bring these up is all of these acts and laws had an impact on the shift to evidence-based medicine. In fact, the Affordable Care Act laid the groundwork for the Accountable Care Organization. And to be an accountable care organization, you actually had to prove that you had an evidence-based practice, an evidence-based system in place for your practice. And then in addition to that, in 2011, you had the governing bodies of medical education shift to a set of foundational competencies for medical education. So in other words, if you wanted to be an accredited postgraduate med school, you had to teach 5 levels of competency in evidence-based medicine. And what's interesting is those 5 levels focus on describing the concepts of biostatistics and clinical reasoning, ranking study designs based on validity and being able to identify threats to bias, and formulating a searchable question in what's called a PICO or PICO format, depends on what part of the world you're from. And then also being able to critically appraise research to evaluate data for validity, significance, and relevance. And then there are 2 other levels, level 4 and 5, that count on the ability of the individual to demonstrate their use of EBM with patients. So we actually don't necessarily focus on those in what we do because you have to have patience to do that. But these acts and laws fundamentally changed the business and practice models in medicine from fee for service to pay for performance. And those things are still changing. And these are the things that actually change the expectations that physicians have of sales representatives. Now, every physician out there is trained in evidence-based medicine. They're taught to question validity and bias and statistical strength. So that's why we base what we do with organizations. We base our work on these competencies to make sure we're aligned with what physicians are looking for. So Dario, how's that answer the question?
Yeah, that's very thorough, Brad. But so you talk about the 2011 mandate for evidence-based medicine training in medical schools. Yeah. And how has that reshaped then the way that sales professionals need to communicate?
Yeah, well, it's really interesting because it has, as I mentioned, it's changed the expectation of physicians and healthcare organizations, not just individual physicians. But you really can look at, I call them the difference between the waiting room rep and the clinical consultant. A clinical consultant leads with purpose, whereas a waiting room rep may lead with product. And the consultant may say something like, well, I've recently critically appraised a study that I believe is relevant to your patient population. I'd like to see what your thoughts are on this, as opposed to, let me show you how our product works, or let me show you how our product compares. So, evidence-based medicine is now beginning to guide how HCPs think, how they make decisions, how they prescribe, and most importantly, how they get paid. Because I don't know about you, but somebody all of a sudden changes how I'm getting paid, it's going to cause some behavior differences in me. So,
that's for sure.
Yeah.
But Brad, some of these salespeople have been, at the game for a long, long time, right? This must have been just a huge, huge shift for them. And maybe what are, sometimes it's hard to teach an old dog a new trick, but what signs indicate maybe that teams are still using some of these outdated approaches?
Yeah, it's a really good question, and it starts with observing the conversations. Focusing on just features and benefits is one thing you will notice, and those are the times you'll get those shorter conversations. So it's also, you look at length of discussion. Things that we see from a field coaching perspective are what you can observe is when representatives avoid using clinical studies, or they don't go deep in a study because they're afraid of what the clinician might say back to them. They show data perhaps, but they don't discuss it, or they lose confidence when they present a concept or some data, and they lose that confidence when they get challenged. So these are the observable behaviors that you see when folks really are leaning back on kind of the old ways of doing things.
Gotcha. So Brad, you introduced the idea of three pillars of credible clinical conversations.
Yeah.
I think you said validity, statistical significance, and clinical relevance. Can you walk us through the sequence and why it matters so much?
Yeah, sure. And again, it's back to the fundamentals. When you talk about how people are trained. So now, since 2011, physicians are trained in evidence-based medicine. Some were trained before as well, but now everyone is. And we have to, when you look at the process for what they're taught, and you can see it on the slide here, it's really a 5-step process. First, they're taught to create a clinical question in that PICO format. What's the patient? What's the intervention that I'm considering? What am I comparing it to? And what's the outcome? So creating a clinical question in that particular format provides you with the best way to search for the data and acquire the data based on the databases that are out there. So they acquire the data next, and then they take the best available data, which is the definition of practicing evidence-based medicine, and they critically appraise it for validity and usefulness. And we'll talk about that in a second. And then they apply it and then assess their results. And so when you look at what they're trying to achieve, and if you kind of look at, I think we've got a graphic for this too. If you look at what they're trying to achieve, they're taught to look for some key pieces: the validity or the bias, perhaps in clinical data, and the usefulness of the data. And usefulness is really broken down into two areas. There's statistical significance and clinical relevance. So let's talk about what the focus of those things are. So when you're talking about validity, you're really focused on, was the study well designed? Was it randomized, blinded? How was it randomized? Did the authors control for bias, for type 1 bias? And can they trust the data? So that's the first thing they want to know. Then once they understand the data that bias has been controlled for and they can trust the data, then it's, okay, what is the statistical significance? Did this happen by chance, or do the results hold up mathematically? Once they're patients. And I think this is where a lot of people, a lot of representatives miss the boat, in that they don't realize that results from a clinical trial actually have to meet a standard for minimal clinically important difference, MCID. And there's a MCID set for most diseases. And that gives you the confidence and the ability to say, these results are clinically significant because they surpass this MCID level. They also have to talk about the size of the result, and the narrowness of perhaps a confidence interval to really drive home that clinical relevance piece of it. So, and it's important to understand the difference, because you can have a statistically significant result without it being clinically relevant, right? So that's why it's important. Physicians look for it in that exact order, right? So they look for validity, significance, and relevance. So that order is important.
Yeah, Brad. So again, like why then leading with results rather than validity will kill credibility with physicians?
Yeah, and I'd ask the audience to think about the times they've been out on a field visit with representatives, and all of a sudden they the sales representative has brand new data. First thing they want to do is talk about, hey, we reduced hospitalizations by 40%. And what that does, based on the training that physicians have now, is it triggers skepticism. They immediately wonder how did that happen, and in whom, and under what conditions. So if you skip validity, you actually begin to lose credibility. And it's kind of like, I always relate it to this. It's kind of like telling a joke, but you tell the punchline before you set it up. So credibility is really built in sequence. So we talk about validity, significance, and relevance. Here's another way, if you like to remember this way: method first, math second, meaning last. So right. Method, math, and meaning.
Cool. So how can reps practically reframe their opening statements or product messages to align with the EBM mindset?
Yeah, so it's really small differences, small pieces of verbiage make a difference, right? So when you're talking about an opening sentence, and I mentioned it earlier, saying I recently critically appraised a clinical trial and the authors did a great job of controlling for bias, or the confidence interval is very narrow, so we know that this is going to be useful across a wide range of your population, given that the study was done in a population similar to yours. So I think they're just leveraging the information and the language helps them just change a few small words to really add that credibility.
Excellent. So, Brad, you mentioned that many reps get intimidated by statistics.
Yeah.
But why is statistical fluency now a must-have, especially when selling to hospitals and value analysis committees?
Yeah, that's a big part of this too. I mean, now you've got value analysis committees, especially in hospitals, or P&T committees that are filled with PharmDs and outcome specialists, and they're all trained in evidence-based medicine, which affects what they're expecting and the way they're looking at the data. So their discussions of data center on study design or confidence intervals or number needed to treat, and then that leads into cost effectiveness. They're not talking features or claims per se. So if representatives can't leverage that language or follow that language, and they're instantly kind of on the sidelines of that conversation. And I think there's a key point here that has to be called out, and that is we don't want sales representatives to become this statistician, this biostatistician. But what we want them to do is be able to understand and explain the story that the numbers tell. And that's what this helps them to do. So it can really help transform them from seller to perhaps advisor, and helping them in that storytelling capability.
So what are a few statistical concepts then that every rep needs to confidently explain, and how do you coach them to do it in plain language?
Yeah, well, so it's interesting. So what you see on the screen there is a list of evidence-based medicine terms that we actually out a glossary as pre-work to any work we do with folks, so that they can begin to familiarize with themselves with it. But when you're talking about key terminology, the ones that we really hone in on is understanding p-value. Confidence intervals or confidence results aren't random. So these are important things to understand what a p-value means. A confidence interval, how precise is the effect? Narrower intervals mean stronger data and more relevant to a clinician in their practice. And that's what all the research is showing, is physicians are looking for relevancy. Make this relevant to me. So talk about number needed to treat. What's the practical impact on my patients? And my hot button, the one that really sits with me, is understanding absolute versus relative risk reduction. Both matter, but you need to understand both of them. And I always use the example that, the statistics you see on a TV commercial about a pharmaceutical product generally talks about the relative risk reduction because it's a larger number. But we need to be able to talk about both, so that we give the clinician a real picture of what the outcome of the study was. So I think that's just, statistics aren't just numbers. They can be trust signals, if you will.
Right.
So I think that's where we go with that.
Cool. What's one simple practice that sales leaders can introduce to help teams become more statistically fluent?
Yeah, there are a couple of things that really don't take a ton to do, but I would say involving your teams. So encouraging a journal club once a month, right? Or perhaps allocating a part of a monthly to a journal club, or even less time consuming perhaps is implementing kind of a stat minute, if you will, at every meeting, so that one representative has responsibility for explaining a concept in the context of one of the clinical studies of the organization. And let's make sure we're using real studies, not hypothetical ones. We want to use them in the practical environment that they're going to be using them. So, and if that's great as a group setting, but also encourage representatives to translate one stat term each week into a sentence that they could use in a conversation from one of their clinical studies. We call this a doctor talk exercise. So it would mean like not saying that has a p-value of 0.05. It's really saying, we can be 95% confident these results aren't due to chance.
Right.
So, you don't have to sound like a statistician. You just have to sound like somebody who understands what the numbers mean.
Gotcha.
Yeah.
So, Brad, you've called critical appraisal the secret handshake of credibility. What do you mean by that?
Yeah. So if you recall from those competencies that we talked about earlier, this is a core competency that physicians are taught, and it's critically appraising a clinical study. Now, I'll tell you right now, if you go ask a physician to see their critical appraisal worksheet, they probably won't be able to produce it. They're doing a lot of this mentally. But we work with organizations with a structured way to evaluate your clinical data, and there is a worksheet involved so that it keeps you on the clear path. So a critical appraisal is just that. It is a systematic way of looking at clinical data for validity and usefulness, and it helps sales representatives plan which data works best for a particular clinician. So it can help target. It can help your confidence in presenting the data and understanding what that story is based on the data. And one of the other pieces that I think the unsung benefits of critically appraising the data is it helps you understand the geography of a paper. So we know from data that's been looked at years ago and continues to be looked at is representatives that have the ability to manipulate the study and show, not manipulate, but show the data, whether it be on a tablet or in the actual study, are more effective than those that just say the words. So understanding the geography of the data in the paper provides that additional credibility. So, and these are things that value analysis committees and P&T committees are now either asking or expecting is, when you critically appraised it, what did you find from a validity perspective and a clinical relevance perspective? So, and that's really what a critical appraisal means, understanding study design, the bias that's involved that could be introduced into the study to keep you from getting that deer in the headlight look when a physician asks you about the bias in a study or says, hey, I think this is bias. So
that's a good segue, Brad. So how can reps use frameworks like PICO to prepare for tougher evidence-based questions from committees and physicians?
Yeah. So one of the first things we ask representatives to do when we're critically appraising a clinical study is to write down what the clinical question is that the authors are trying to answer. So in what patients is the study taking place? What is the intervention at which they're looking? What are they comparing it to? And then what's the outcome that they're expecting to see? And when you understand that, and when you do that, you're now putting yourself in a position to align that with physicians that may be asking the same type of question, right? So if you're able to relate that clinical question to a clinician, first of all, use it ahead of time in your planning to choose which data you use with which physician, which study you use with which physician. But then within the conversation, you can begin to talk about the clinical question that the authors are answering.
Right.
So it makes a big difference.
So, Brad, you've trained reps to appraise not just their own studies, but also competitors.
Yeah.
How does that shift the power dynamic in a sales call?
Well, it's just as we have representatives critically appraise their own studies and look for those areas where there might be strengths and perhaps weaknesses that others may take advantage of or physicians may question. We actually can use that same framework, that same critical appraisal framework, to look at competitive data within company standards, within the company regulations. You can look at competitors' data to better understand where the strengths of that study lie and those data lie, and where the potential areas for bias are that you may be able to be a resource and bring up to a clinician. Again, if you're allowed to discuss competitive studies, but it gives you more credibility by being able to talk across the disease, not just specifically to yours. So, yeah.
And if you're a sales manager listening today, what's the best way to start integrating critical appraisal skills into coaching and role play?
Yeah, really good comment here, or question. And I think the best way to do that, and what we've seen most effective, are two things. One, observer checklists, making sure that you have the key behaviors that you're looking for on a checklist that you evaluate as you're listening to and talking to clinicians, or your representatives talking to clinicians. And the other, at the very positive end of the spectrum, would be integrating those observations into a field coaching report, so that they are permanent part of your process.
Right.
And I think those are some of the key areas, but involving the whole organization, including looking at and auditing the current messages that you have from a marketing perspective, and saying, okay, are we leading with results, or are we setting up the joke before we tell the punchline? Right.
Gotcha.
Yeah.
So Brad, you described a powerful transformation from transactional interactions to clinical consultations.
Yeah.
What triggers that change?
Well, some of this is not new. Some of it is, and we spend a little bit of time on this, our typical consultative selling skills, shifting from telling to asking, but having the confidence in the clinical data helps you do that. So, how do you currently handle resistant depression cases? Because the authors in this study found this. How does that match your experience? So, we really want to focus on relevance, not repetition. And it all, it's how you frame the evidence. And I've mentioned this a couple of times, but, I recently critically appraised a randomized trial that might apply to your patient population.
Right.
There's several different phrases that we can go through.
Cool. Can you share a short story of a rep who made the leap and how it changed their access and credibility with physicians?
Yeah. I tell you, it's really, it's an interesting story. It was, and maybe that's why absolute and relative risk reduction is. He threw out some result numbers, and the clinician asked him, well, is that relative or absolute? And that deer in the headlight look came up.
Yeah.
And sure enough, he had no clue. And what happened as a result of that is a 30-minute conversation or lecture from the clinician on what the difference between relative and absolute was. Totally took it away from product.
Yeah.
And went into relative risk and absolute risk. So, post that conversation, this representative really doubled down on the language they used and the biostatistical terminology, and was able to integrate those into their sales conversations, and continued to grow in the amount of time they were spending with clinicians.
Cool. So Brad, for sales leaders, how should success metrics evolve to reward clinical fluency instead of call volume?
Yeah, that's a key piece, because I know we end up looking at a lot of activity metrics, and it's great if you can integrate the EBM observation pieces into your field coaching report. But really, what we've seen in the past is that to begin to evaluate length of conversation, accessibility, how much depth in conversation that your representatives are getting into, it's really beginning to focus on some of the things you're already evaluating. I'm not trying to get you to do too much different, but begin to focus on that length of conversation, depth of conversation, how often they have access, how often they're asked back. I had a representative once that in Michigan, of all places, and literally the back door was open to him because he had such a solid knowledge of the evidence that clinicians would welcome him in, so that he could have a discussion, not a detail, but a discussion around the data about particular patients or particular populations. So.
Cool. Hey, Brad. So we're coming up toward the end of our session here. It's been super educational. I've just got a couple of questions that I'm going to throw out to you.
Sure.
the first one, and certainly everybody, you see the contact information on this page. If you have any questions or if you want to get in touch with Brad or myself, please feel free to do so. But one in particular, so what are, maybe some of the triggering events or some of the situations in a pharma company that might sort of lead them to want to, refresh their clinical selling skills or their
Sure.
evidence-based selling skills?
Yeah, that's a good point there. So launch is always a key indicator of the need, because typically you're going to have, for a new product, you're going to have new data, new studies, and this is a perfect environment in which to increase the clinical selling competencies of the sales team. Another situation that this has been very useful was one of the top 5 pharma companies actually had launched a product, and they didn't do the business development work just due to dynamics in the company. They didn't get a chance to do the business development work they wanted to ahead of time, so they weren't hitting the market share targets that they wanted. So they actually instituted this post-launch, but within the 6-month time frame, because I think if you look at all the data, and most people on here probably know that first 6 months post-launch determines the amplitude of the market share line and the slope of the market share line for the life of the product, based on ZS and a bunch of other organizations. But so post-launch, when things weren't going quite the way they wanted, that was another area. And then always when there's new data involved, it's always good to refresh and critically appraise and get everybody together to walk through and refresh their language, if you will, especially around new studies.
Great.
And then lastly is new rep training.
Mm-hmm.
That's always a good place. Hey,
Brad, just tell the audience a little bit about how you typically work with a client. Is it a program? Is it just tell us the nature of this or the intervention?
Yeah. So typically we'll engage with an organization and spend a good bit of time looking at what their goals and objectives are to make sure that this is going to meet what they need. And then once we do, we begin to tailor this. We'll call it an engagement, but it's an engagement that can be delivered in 4 hours or 8 hours, virtual or in person, where there's about probably 15 minutes of video pre-work, but then there's probably an hour's worth of pre-work, getting the representatives ready as they critically appraise their own study in preparation for a workshop where they actually have to leverage that information to practice in a practical environment, to get their lips and mouth around the new language. So again, in that 4 hours to 8 hour workshop, they get to practically use this information. And then from there, we evaluate to see if there are any areas that we need to continue to focus on from that perspective. So it's really just a phone call to kick it off, and then some discovery, if you will, and then tailoring, and then a workshop, and then some pre-work workshop and follow-up.
Excellent.
Yeah.
Cool, Brad. So I think that wraps things up for today.
Great. Well, let me just leave with this. As I mentioned before, credibility is built in small intentional choices. Evidence, EBM gives us the structure, validity, statistics, and clinical relevance, but the power is really in the language we use to express it. And I'll use the golf analogy one more time. If you're at the tee and you're looking down this great, beautiful fairway, and you make this great swing and it feels right, but your club head was 1 degree off, well, 200 yards later, you're 20 to 30 feet off target. And sometimes that means being in a bunker or changing your shot selection for the next thing. And that's the same thing that happens in a call with a physician. If you're 1 degree off, it can take that conversation down a different path. So let's make sure we keep that club head steady and straight. And instead of saying stuff like, "We did a study," say that, the investigators conducted a clinical trial. And those are the type of simple things that matter. So when we speak the language of evidence, we earn access, credibility, and influence. So thank you all for being here. And please reach out if you have any questions or comments.
Thanks, everybody.